Alright, let's come back and finish up the anatomy. Just a little bit of function of the large intestine, but nothing very complicated.
Everything else. No one eats the brown rice.
The large intestine is also known as the colon. By this time, we're done with the chemical digestion and absorption of carbohydrates, proteins, and fats. Within the large intestine, there is still chemical digestion occurring, but it's being done by bacteria. They're using their enzymes to break down plant material such as cellulose, that we do not. Yes?
Are there any bacteria in the small intestine?
In a sense, yes. They don't live there. If they live past the hydrochloric acid of the stomach, there might be bacteria in there. Okay? But typically, if they're allowed to proliferate, you get diarrhea and you get sick. So most bacteria are killed within the acidic pH of the small of the stomach, or any digestive juices. There's no normal growth. They don't live there like they do in the large intestine. Remember, that's the reason for the Peyer's patches, the dense amount of lymphatic follicles that we have in the ileum in case they move into the small intestine via the sphincter. So this is the ileum right here. It is the last 10 to 11 feet or so of the small intestine, and it empties into the cecum portion of the colon. This is this blind pouch here. And so there is a valve. It's not so much a tight muscle as it is a flap, so it's called the ileocecal valve. So we'll add that to our list of sphincters. We have the orbicularis oris at the mouth, the cardiac sphincter between the esophagus and the stomach, or gastroesophageal if you wish, the pyloric sphincter between stomach and duodenum, and now we have the ileocecal sphincter between the ileum and the colon. So we don't have any sphincters between the parts of the small intestine itself, all right, just between those larger organs. Also coming off of the cecum, we have the appendix. Its full name is vermiform appendix, which just means worm-like. It also has a high number of lymphatic follicles, but not for any functional purpose, as we can see with the ileum, because it's normal for bacteria to be present in the appendix. Okay. I did do some reading a couple of years ago. A couple of British authors theorized that the purpose of the appendix was to keep a colony of your normal flora in case you had extensive catastrophic diarrhea. You would have bacteria right there ready to repopulate the large intestine.
I read a similar article that mentioned the normal microbiota of the digestive tract, and that the microbiota of the appendix act as a competitive inhibitor.
Oh, really? Okay, I haven't read that one. I'll have to look at it. Because are you born with bacteria?
No.
No. So would they get there by the food that you eat, or migrating up the other end? So the food that you eat is sterile, so some of it could come that way, but like we were just talking about, most of that bacteria on that food is going to be killed on its passage down, okay, so it's more likely to move up the other end than to migrate. It's why, why finally decide to live in the colon, why not the ileum then, if it's going to take place there. So there's other conditions that make that acceptable. Now, just naming off the parts, so we have the appendix, the cecum, this is the ascending colon.
Why does the appendix burst sometimes?
All right, so if it does, if bacteria do grow there, sometimes it can get twisted, all right? So it can get infected with the wrong type of bacteria. The bacteria can break through instead of being in the lumen, They move into the tissue itself, and the lymphatic follicles enlarge. It's a small space, so if the bacteria grow within that tissue, then it gets larger. And that rupture then spews bacteria into the peritoneal cavity, which is supposed to be a sterile space. Now we've got infection throughout the peritoneal cavity.
Professor,
Yes?
why doesn't this stuff just get out into the large intestine from the appendix then? Why does it burst?
Well, because it's not just in the lumen, it's out in the tissue. So it's like kind of having an infection under your skin. The bacteria stay on the surface of your skin, it's fine, or on the surface of your tonsils. But if they pass through the epithelial cells lining the appendix, now they're in a closed space, the lining of the appendix and the serosa of the appendix. And that only has so much room in which it can
So it's
expand.
not necessarily the appendix bursting, it's the lumen.
It's this outer wall of the appendix that's ruptured because of the growth of the bacteria in the tissue, not just the lumen. So the appendix is a sac that looks like this, and it has the lymphatic follicles. But if our bacterial infection gets in here, just like your finger can become swollen if it gets an infection, and this swells, then this portion here can rupture. Okay? So it's not because this is full of bacteria, it's the bacteria in the tissue of the wall of the appendix itself. All right, so ascending of colon, the corners are known as the right and left colic flexure, or since this is on the liver side, it's known as the hepatic flexure. It's slightly lower, more inferior than the left side, just like the right kidney is slightly lower than the left side because of the large presence of the liver. The ascending colon is retroperitoneal. It has no mesocolon, all right? However, except for the appendix. The appendix does have a mesocolon. Has its very own mesentery, as you can see right here. And the transverse colon has the mesentery. Remember the transverse mesocolon? So the transverse colon is intraperitoneal. And we get to the left colic flexure. Or splenic flexure. And we have the descending colon, which is again retro. Every other structure here is retroperitoneal. This double curvature is the sigmoid colon. It has a mesentery. Right, so anything with the mesentery is intraperitoneal. Those structures without are retroperitoneal because the peritoneum is kind of like laid over it and holding it to the posterior abdominal wall. Now you can see this band. There's actually 3 of those. So this band is disappearing as the transverse colon is hanging down and we're looking at a posterior band, but there's 3 of them. One of them actually leads to the appendix. So sometimes surgeons who have a difficult time finding the appendix, obviously not if it's inflamed, but if they're in the abdominal cavity doing surgery, they'll often remove that just because they're there already. And so those bands are bands of longitudinal muscle, limited just to these 3 bands. And they are known as tinea coli. So So when we get to our muscularis externa, we'll mention that again. We have an inner circular layer, but the outer longitudinal layer is limited to the tinea coli.
That's a muscle?
Longitudinal muscle.
What does it do?
It's in a state of tone. It creates these pouches or haustra, but it also is part of the peristalsis that occurs in the rectum. In the colon. All right, and then finally we reach the straight portion here, which is the rectum. And then the last couple of inches is the anal canal. I don't have on the lab list these little fatty attachments, epipoic appendages. The name of it, you don't have to worry about them. Okay?
What are they for?
Adipose protection. Not enough really to do anything. What would the blood supply be to the large intestine? Superior mesenteric. Does that do all of it? Watch it. So we'll put up here the superior mesenteric artery. What's the nerve supply? The parasympathetic nerve supply. What are the two choices? Vagus or, to help me think better. What's the other parasympathetic? Splanchnic, which one? Someone like you were saying pregnant, but I heard those. No. Parasympathetic, pelvic, splanchnic. Remember the PS relationship? All right, so pelvic splanchnics would be doing parasympathetic, and the thoracic splanchnics and lumbar splanchnics do the sympathetic. So that's parasympathetic, and sympathetic would be thoracic, like the least splanchnic, and lumbar splanchnics. We'll do sympathetic. Okay? However, that's not all. That only lasts to the splenic flexure. So superior mesenteric artery does all of the small intestine and ascending colon and transverse colon, and then overlaps a little bit at the flexure with the inferior mesenteric artery. Same thing, vagus nerve. Sorry, didn't mean to put this here, guys. It's only vagus. We'll pick up the pelvic on the other side. Vagus nerve does the same distribution. Inferior descending colon, sigmoid colon, is done by the inferior mesenteric artery. And this would be parasympathetic, is pelvic splanchnic. Is that going to activate the colon or inhibit it? The vagus and the pelvic splanchnics. What is the role of parasympathetic?
Stop.
Rest and digest. So vagus increases esophageal and increases gastric motility. Remember what I wrote on the board earlier this afternoon? Vagus activates the stomach and increases its motility. Sympathetic inhibits it. So when we get to the descending colon and sigmoid colon, it's going to be the pelvic splanchnics that increase peristalsis and sacral splanchnics that decrease. And our blood supply is inferior mesenteric artery to the top of the rectum. And then we would have middle and inferior rectal artery. Okay, so this would be our blood and nerve supply for descending colon. All right, let's look at the mucosa. Remember the schematic pattern that I introduced you to for the stomach and the small intestine and the large intestine? The line drawings of the mucosa. Kind of drew the three of them over here on the board. I'll draw them again. You guys are burned out on that test. So the stomach, we had gastric pits and gastric glands. Of course, the muscularis mucosa. The small intestine. We added villi to the intestinal glands, or the increase in surface area. And now for the colon. It's much more simple. It's closer to the appearance of the stomach with a really even surface, but without the gastric pits. So in the colon, we just have intestinal glands. Okay. So looking at the general plan for the colon, for the mucosa, we're still looking at simple columnar epithelium, okay? In fact, this is going to be through the rectum because the two look indistinguishable. So our mucosa is simple columnar epithelium in the intestinal glands with many, 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 many goblet cells. 25% of the columnar cells in the colon are goblet cells, but it looks like at least 50%. We'll look at this illustration here. And then we would have our loose irregular connective tissue. Finishing off with the muscularis mucosa. No cilia, still microvilli. And we absorb water across the large intestine. The goblet cells are there for the production of mucus, obviously, and the lubrication, not so much the protection of the villi, as it is lubrication, because as we're absorbing this water, the fecal matter is getting drier and drier. Okay, and anybody that's been constipated knows that it really helps to have some lubrication in there. This was really brought to illustrated the importance of this with a home care patient that I had, elderly. He was still quite a lot of energy, and he still worked full-time. He was 80 when I first met him and had a full-time job and traveled between 2 homes. So he would go to one home and I would see him for a while, then he'd come back to where I was at graduate school. And a friend of mine who was a home health care nurse for the county said, you know, this guy lives right there where you do, and you need someone to come and give him an enema every few days. So I went and talked to him. And when he was 5 years old, his parents lived out in the agriculture area, and he had gone out into the farm and eaten lima beans. I hate lima beans. I don't know who would go out and eat them voluntarily. because they had been sprayed with a pesticide. And I don't know why, how his esophagus survived, his stomach or his small intestine, but the lining of his large intestine was destroyed by the chemical burn from the pesticide. So he had two problems: the adhesions created as a result of that scarring, and the loss of the goblet cells producing the lubrication. So starting at the age of 5, the only way he could get rid of fecal material was to have high colonic enemas. And by high, I'm talking about transverse colon. Okay? So he went on, he had to have these every 2 or 3 days. That's about the standard time that you have a bowel movement, 1 to 3 days. He went on to go to vet school, became a veterinarian, worked in World War II over in Asia, taking care of cavalry and other animals, and came back and worked as a veterinarian and had several jobs. And so when I met him, because of his travel, he wouldn't always get this enema every 2 or 3 days. Sometimes it'd go a couple weeks. And you can imagine how you would feel not having a bowel movement for 2 or 3 weeks. So it consisted of, I spent a whole evening over there. So he had a glass pitcher that looked like a blender, a glass jar that was suspended from an IV pole, and a latex tube about the diameter of my thumb that had an expanded end that fit over the bottom of the glass jar with a binder around it. And I would fill that up with lukewarm tap water. It would hold about 2 quarts. And he would take that, he would take up to 2 to 3 quarts at a time for a total of 8 to 10 quarts of just tap water. And I would see his toes start to curl, and I'd encourage him to take as much as he could, and then he'd say, okay, that's enough. And I would take out the latex tubing, I lubricated it with Vaseline. He thought I did a wonderful job because I was an anatomist. I just went slow. And you could actually feel the tubing just under deep to the skin and the transverse colon. And I'd clamp it and pull it out, and then he had a bathroom right off the front bedroom. His wife would be puttering around in the back. And I'd sit on the couch in the bedroom and read my research papers, and he'd read his work papers. And he'd be in there for about 15 minutes, and he'd come out and we'd do it all over again, 2 or 3 times. And then we would change, and I would do soap suds enema. And I just wash my hands with ivory soap and rinse it in the water, and would repeat the whole process with the soap sud enema. And then we repeat it 1 more time with the normal saline. I'd add table salt to the solution. Now, on an aside, the weirdest enema I ever gave was milk of magnesia and molasses. It looks like poop when it runs out. So I did it to a patient who was in her hospital bed, and I still have the letter I wrote home about. I had this whole chemical formula that I made up for my parents about how it worked. But anyway, back to this gentleman.
Okay.
The sugar, I think, took gas out or something. That's what I made up, or made gas, and that moved things out. I don't know what I came up with. And so this took from about 6 o'clock in the evening to 11:30, or 6:30 to 11:30. And the first night, he pulled his boxer shorts back on, came out, sat on the bed, and started to write me a check. And I just started laughing, and he's like, "Do you know what this looks like?" So he was very careful. He was very careful to write RN after my name. And I did this for almost 3 years until I was finished with graduate school. And he never told his children, because when his son-in-law came to stay with him, he was all concerned about how we were going to schedule this without his son-in-law finding out the 5 or 6 weeks they stayed for the summer. I remember asking him, why don't you just have your wife do this? And he said, because that's not why I married her. She's my wife, and I've always had others. So in his other home, he had a special bathroom built just for this procedure. And I said, well, why did you have a colostomy? And a colostomy is when the large intestine, the colon, sometimes it's done temporarily just to allow the colon to rest. Someone has ulcerative colitis, or it's done for colon cancer. They might resect out a large segment of it. If the colon is brought to the surface from the ascending colon, there hasn't been enough time for water reabsorption. So it's very liquid and it's constantly draining, and because of the bacteria, it's very foul smelling. Okay. They bring it, suture it to the skin, opening in the skin, the stoma, and then use a skin adhesive to attach a fabric padding that the plastic bag then can be attached and removed. Right? If the opening is on the left side, there's more time for the reabsorption. The fecal matter is more solid. And often they can train themselves reflexively to have a bowel movement on their own. So they'll have a bowel movement once or twice, once every day or so. And the bag is there just in case of accidents, but they don't pass a lot of gas, and it's not as embarrassing for them as the one that's constantly draining. And he was very happy and relieved that he had never had to have that done. In fact, when he was a child, his aunt, who was in her mid-20s, had already had this procedure and had to have high colonic enema, so it was comforting to not be the only person he ever knew of that had this. She was dating, it turned out a dentist, sorry, pre-dental people. Did you know that dentists have the highest suicide rate? So, anyway, of medical professions at least. So she was dating this dentist, and he was about 45 minutes late to pick her up for the dance at the local fire station, and her friend said, he knows where it is, just come with us. And so she did, and he showed up at the firehouse, and while they were dancing, he shot her in the back with a small caliber pistol and destroyed the sacral region of her spinal cord. So those pelvic splanchnic neurons no longer work, because if the spinal cord is damaged above in the lumbar region, you can still have reflexive control sometimes. And she, of course, was a paraplegic. And so after he grew up, he actually took care of her and then would take her on trips and carry her in and out of the bed and breakfast places and stuff. But it was a really good learning experience for me, and I often relate it to illustrate the importance of those goblet cells and the presence of the lubrication factor that they provide. Of course, he also had the adhesions, and so as it just got so slow, that just gave extra time for the water to be reabsorbed, and then it was kind of a losing balance between absorbing the water and the friction created in the adhesions, and it just couldn't go any farther, so that's why we would do such a high. Most standard enemas that you can buy in a drugstore, or they give you the night before surgery, are about a 1.5 to 2 cups. Yes?
I have a friend, one of the ones in our group is just really weird with bowel movements. She went to Europe for 2 weeks, couldn't go at all. So after like a couple days, she was taking all these, medicines, trying to relieve all that pressure, and literally for, I think she was there for 16 days to not go to the bathroom.
Oh.
So when she came, and then of course she gained like 20 pounds of water weight as a result. And staying in Italy, I'm sure you have a little bit more amount than usual of eating all that great food, but coming back, she doesn't remember hugging her mom when they got to the house. She just pushed her aside and went straight to the bathroom. But I told her, I was like, I don't think you could successfully do that again, Jen. You can't not go for over 2 weeks. It's really hard on your body. So what is that time frame where it can actually be fatal as a result of?
I'm not sure of the time frame. I do know, not personally, but I know of a close friend who, because of probably drug use, because prescription drug abuse can result in constipation, was driving down Highway 50 to a new job, felt ill, pulled over to the side of the road. A new faculty job at Sac City, felt ill, pulled over to the side of the road, called the ambulance herself, and was taken to one of the local Kaiser hospitals, and ended up dying that night as a result of electrolyte imbalance from her impact. It was an impaction. It wasn't just constipation, it was an impaction. Which is a shame that it had to go so long, because there are, when I travel, I told you guys about going to the bathroom at my high school, okay? So when I travel, just the change in scheduling, it's not so much an inhibition, I don't think, like it is with the bathroom or being in a strange place. Just traveling back to my parents' house or whatever. Before I travel, I always pick up some laxative medication, just because it throws my whole schedule off. And I don't like to go more than a couple of days. So I just know that I need to take a laxative with me. Now when we went to China, we took an anti-laxative, just in case we had some bad bacteria or whatever. And so I don't know how long it had been that this particular woman had not had a bowel movement. It's not so much the stretching and the buildup as it is the water is, the reason we reabsorb water is there's active transport of sodium. Chloride follows passively and then the water follows that. But with the toxin buildup and then with the sodium, when you absorb sodium, you usually secrete potassium. So if you're not absorbing the sodium, and it's one of the problems, too many laxatives, as you know, with anorexic individuals can throw off their electrolyte balances and result in heart problems. But the friend that knew this particular person, I don't know that he ever got a hold of her cause of death. It was there, they called him first because she was divorced. And I don't know that he ever got the hospital record to exactly what the cause of death was. So I'd imagine it would be variable. It may have been, and also the drugs that she was taking may have contributed to her heart problems. But it was kind of this colossal failure of body systems as a result of everything. So I don't know a specific timing or whether it has to do with what kind of food you eat either. But some people deal with an irregular diet by taking laxatives regularly. That can lead to problems because your intestines can forget how to function if they're constantly using a chemical fluid drive to cause that to occur. Most laxatives will block that sodium and increase the amount of fluid that's in the intestinal tract. You can do, if your diet isn't adequate, you can just take the fiber, the psyllium, or other types of fibers, either as pills or mix it into water or whatever, to avoid doing a chemical type of laxative. A morning student that we had, she said when her baby was born, she nursed her daughter. She nursed her, but she had constipation. She had to give her a baby laxative until she was about 5 or 6 because she just never could get regulated. And so she was asking why, since she nursed her, and that was supposed to be a really, healthy type of food. And I said, well, it may just be that the nervous system wasn't as well developed to provide the reflex that we'll talk about in a few moments that allows for a normal defecation pattern. But I mean, that doesn't answer your original question, but it certainly can lead to death.
What's that tea that people take to?
I'm not sure. A laxative tea?
Yeah, my friend takes it, and I suppose.
Caffeine can have a laxative effect as well, again, because of the fluid and movements and stuff for that. All right, so that's the mucosa. Our submucosa is a standard, dense, irregular connective tissue. All right, nothing unusual about that. The muscularis externa. We have a circular, an inner circular layer. And the outer longitudinal layer is what is modified to form the Taenia coli. But we still have peristalsis, all right? So it's just a slight increase in the tone that creates those haustra. So the longitudinal Taenia coli. And then our serosa is still the visceral peritoneum, certainly for those components that are intraperitoneal. And then it would be found only on the lateral anterior surfaces of the ascending and descending colons that are retroperitoneal. All right, so here's an image now of the rectum. a little bit wider. This is, except for the superior rectal, the rest of it is found without any serosa. But it still shows the simple columnar and goblet cells. Okay? It's just that the rectum's not going to have the serosa. The last couple of inches is the anal canal. And that is lined with the same type of epithelium that we see at the other end, the mouth and the esophagus, a non-cornified, stratified squamous epithelium. Okay? These anal valve grooves here are created by the middle rectal veins. And remember, if those get enlarged and dilated, we have internal hemorrhoids. Whereas the external hemorrhoids down here are due to varicosities of the inferior rectal vein. Two sets of muscle. This is our last sphincter. The internal anal sphincter is just a thickening of the normal smooth muscle forming the wall of the tube. And then the external anal sphincter is a component of the levator ani, that skeletal muscle. All right? So the defecation reflex is the same types of stimuli and innervation that we saw with the urethral micturition reflex. So as fecal matter moves into the rectum, the reason it doesn't move on through is because of contraction of the external anal sphincter. What is the nerve that's maintaining contraction of the external anal sphincter? I'm on page 54. Same nerve that maintains contraction of the external urethral sphincter. Pudendal. Okay, because it's skeletal muscle. So that's going to be the sympathetic. Our sacral splanchnics are going to be keeping the rectal wall relaxed. And as more and more fecal material moves into the rectum, it starts to stretch. Just like the bladder wall stretched as more urine flowed into the bladder. That sensory fibers travel back to the spinal cord and inhibit the sympathetic and activate the pelvic splanchnics, which cause the peristaltic contraction of the rectum and the relaxation of the internal anal sphincter. Now, if you're potty trained, you still won't go to the bathroom, all right, until you're in the appropriate place and you feel comfortable. And then the pudendal nerves keeping the external anal sphincter contracted will be inhibited. And the external anal sphincter will relax, and then peristalsis will contribute to defecation.
So the pelvic splanchnic goes to the internal?
So pelvic splanchnic and sacral splanchnic are going to the smooth muscle of the rectum and the internal anal sphincter, because those are both smooth muscle. The sacral splanchnic are keeping the rectal muscles relaxed, so there is not peristalsis, and the internal anal sphincter constricted. Then, with stretch receptor activation, pelvic splanchnics will increase peristalsis and relax the internal anal sphincter. Pudendal will maintain the external anal sphincter constricted until inhibited by upper motor neurons. And when that relaxes, then defecation can finally occur. All right. We're done with anatomy and physiology of digestion. We have metabolism and hormones left. So let's stop there and give you guys some time for lab. And let's look at taking the quiz at 3:30. Okay? It's exactly the same amount of time we had this morning. And they asked for another 5 minutes after that. So we'll look at 3:30 and then I'll check with you guys. Okay? But for now, we'll plan on 3:30.